Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Balodi. And today we have a repeat guest, a friend of the podcast, a member of our Down Syndrome Center, Dr. Tarin Santamaria. Dr. Santamaria is the one who runs our behavioral clinic at the center, which is something we'll be talking about a little bit as we go through this podcast today. But one thing that I've noticed that there are times that when I will send a patient to Dr. Santamaria, and like many things in medicine, and I think in healthcare in general, there are a lot of alphabet soup that comes out afterwards, and it's something that I'm sure that as providers, but also parents listening to the podcast, we would love to know more about what these services are and how they are available and to which patients they are available. And oh my goodness, so much to talk about. But before we get into that, Dr. Santamaria, do you mind reminding our audience who you are, what you do for us here at the center, and we'll take it from there.
Of course. Hi, everyone. I'm Dr. Tarin Santamaria. I'm a pediatric psychologist, and I'm also a school psychologist by training. In our Down Syndrome Center of Western Pennsylvania, I see individuals 0 to 26, and I focus on the initial appointment being the psychological evaluation, and then I also provide outpatient therapy to our population. And in those appointments, I do a lot of behavioral consultation. I target social emotional needs like anxiety or depression, do a lot of parent coaching for behavioral strategies and also educational advocacy.
Wonderful. And I, for our local families, especially those within the state of Pennsylvania, many of you, we have had you meet with Dr. Santamaria in the past. And one of the wonderful things about this behavioral clinic is that we're available to do this in person or virtual. And so there are a lot of ways that you can connect and proceed from there. One of the things, in fact, I just had a conversation with a family within the last couple of weeks, is that there's a misconception that somehow there is a behavior gene on the 21st chromosome. But I really don't think there is. I think that there are some common pediatric issues that people may attribute to having Down syndrome, but are not related, I don't think, anything genetically on the chromosome. I'll give you an example of somebody who I might see in my clinic, and then Dr. Santamaria, maybe you can take it from there in terms of how you
Sure.
would approach. So let's say there's a 5-year-old, they started kindergarten a few months ago, and there was some initial transition to kindergarten difficulties. But what the parents and the teachers are noticing is that this particular 5-year-old is having challenges, let's say sitting in the circle time, or maybe some oppositional behavior, saying no when asked to do something, or trouble transitioning from one task to the next, or maybe some attention-seeking behaviors. And boy,
Mhm.
the teachers are at their wits' end, and also the parents too, in terms of trying to figure out what to do. So these are often families where I'll give them some brief, general kind of things in the clinic, and then I'll send them to you, which is such a wonderful thing to be able to do. And how would you take it from here? How would you approach this patient, and what kind of services may be available for them?
Sure. So it's probably kind of a two-prong approach. If the child is in school, in a public school, I would say, hey, reach out to your IEP team. A lot of our individuals go into school with an IEP, and figure out, is there a behavior plan in place? They can request what's called a functional behavioral assessment, or FBA. And that's where a behaviorist or school psychologist goes into the classroom, observes the behavior, tries to figure out what's the function, like why is the behavior happening, and then come up with a plan to address it. And there'll be preventative and kind of reactive strategies that are put in place. So that kind of covers school land, because then once the plan is in place, all teachers will be consistently implementing behavioral strategies, and hopefully they can manage in the classroom. My
Well,
other approach, oh, go
one,
ahead.
one,
I'm sorry.
one real quick question
Yeah.
about that, because this is something that does come up quite a bit in the clinic is, let's say there is this behavior in the school, but the
Mhm.
school then says, parent, you figure out how we should take care of this issue.
Mhm.
Um, and often these well-intentioned parents are really racking their brains about how do we get this patient or this person to behave better in school. How would you address that with the family?
Sure. So a lot of times when that happens, then parents end up making it to me too, which is kind of like the other part of the second prong
Yeah.
approach. When I do a psychological evaluation, I'm assessing symptoms and needs and trying to determine what we call the medical necessity criteria for different levels of behavioral health care, which means I'm trying to figure out what type of therapy service would be most appropriate based on the frequency or severity of the behavioral needs of the child. So if I do a psych eval on this kiddo and I say, hey, this kiddo would benefit from outpatient therapy with me, then my approach would be, depending on if it's weekly or biweekly or monthly, doing behavioral interventions as part of outpatient therapy, and also collaborating with the school when and if possible. And what's been cool since the pandemic is the telehealth options have really opened up my ability to collaborate with the school, because I can set an outpatient therapy session with the family and invite school personnel to participate via telehealth, and then kind of do collaboration in that way. So that's been really awesome in the
Yeah, and
last several years.
I guess what I'm also wondering too is like I'll have these families that'll be in the clinic and they'll say that these behaviors are happening at the school, and I'll ask, well, is there a behavioral plan as part of the individual educational program or plan IEP? And they'll say no, there's no behavioral component.
Mm-hmm.
And how wouldn't you say, and correct me if I'm wrong, but this is really a responsibility for the school to at least begin with those things you were talking about earlier, the behavioral analysis, why is the behavior happening, and then coming up with techniques for all of the teachers and therapists to use. Like that's on the school, is it not?
Yeah, so when a child has a need within the school and has an IEP, it doesn't matter if the kiddo is identified just under speech and language impairment for the IEP. Whatever the need is, the school should assess and meet those needs. So if the school is having complaints about behavioral concerns, then they have to address it through their systems that are in place to for addressing behavioral concerns. And that would be an FBA. A lot of the districts will have a behaviorist or a school psychologist or some similar titled person that helps teachers and helps to implement interventions within the classroom. So those are conversations that I would definitely have with the IEP team. Most of our individuals have like a point person on their IEP team that we talk to when new or different concerns come up. So parents can reach out to that person and formally request an FBA and a behavior plan.
Awesome. Yeah, I try to empower the families, in this way where it's like, you don't ask the school to tell you how to help with your child's behaviors at home. And similarly, while the school may ask for suggestions, it shouldn't really be on the parent alone to come up with these issues, how to address these issues that may come up. But now here we are. We've got this 5-year-old. They've got the behavioral plan. The school is doing the best that they can. The same situation is happening at home. We send them to you. You were talking about the outpatient services. So let's get back to that. So
Yeah.
so now you've seen them, you've assessed them in your clinic. Tell us where you go from here.
Well, a lot of times when there are behavioral concerns in one environment, they are in others. So even though we're saying, hey, school, please assess this and address this need at school, I think that there is still a need to address it for outside of school land. So coming to me for therapy is, I think, a really good option. If there are needs that are more than what I feel like I can manage within my clinic. So I'm saying, hey, this frequency or intensity of need is greater than outpatient therapy can manage, I might make a referral to a higher level of care or a more intensive service option. I'm not sure if that's what you're asking with that question
Yeah,
or not.
yeah,
I'm sorry.
yeah, no, definitely. And I think again to highlight for our families this idea that, we are very blessed here in this area to be able to have you on our team, Dr. Santamaria. And I guess before we go to the next step, if a family does not have an option like that, are
Mhm.
all psychologists equal in some regard, or is there something specific that a pediatric psychologist, or even, as you would say, someone like a specialist in behaviors that you see in people with Down syndrome, are there benefits to getting that specialized, or is any psychologist the same as anyone else?
So I would seek a psychologist that specializes in work with children.
Okay.
I think a psychologist that works with populations of individuals that have developmental delay would be helpful. There's not a whole lot of psychologists that might advertise that they work specifically within the Down syndrome community, but maybe similar populations like the autistic community. So definitely finding one within some of those categories could be really helpful.
Awesome. Okay,
Yeah.
now tell us more about the higher levels of care. What are they? This
Sure.
alphabet soup that comes out sometimes with those things. What are they? Who would benefit from them? Those types of things.
So in Pennsylvania, we have the hierarchy that I like to think about. Okay, so outpatient therapy is the least intensive service modality that's available to families. And this is where you bring your child to an office or do telehealth. And a lot of times this is like weekly for 45 minutes. Sometimes it's bi-weekly or monthly. Sometimes I see our families as needed. And so that's considered the least intensive. The next step up, we call it wraparound as a nickname, but formally it's called Intensive Behavioral Health Services, or IBHS. The difference between outpatient and IBHS is that IBHS happens where the child is. So this service can go into the home, it can go into the school, and it can go into the community. So it's more intensive because it goes where the child has a need. And the therapy also happens more frequently and for a higher number of hours. So it's not going to be once a week for 45 minutes. And there's a few different roles under that IBHS umbrella, but oftentimes it's a more significant, we call it like a script. There's a higher number of hours provided every week.
Okay, and then and that you said is provided in which location? Home, school, both?
Yeah, it can kind of be, it's wherever the child has a significant need. So it can happen in the school, it can happen at home, and it can happen in the community. And sometimes community, I mean, like if a kiddo has difficulty with darting an elopement in the grocery store, the therapist can go with parents to the grocery store and practice safe walking and other, safety or social skills. So yeah.
How does someone go about getting those services? Do they have to see you first, get a referral from their pediatrician? Like, how does that work?
So these rules kind of recently changed. Right now, you can get a script for IBHS by coming to see me for a psychological evaluation, and I could write the script for wraparound within my evaluation report. The other way is asking the pediatrician to fill out what's called a written order form, and there's different ones depending on what county in Pennsylvania you live. There's a couple other clinicians that are able to do that now. Psychiatrists and some licensed therapists can also fill out those written order forms. The individual that does it has to be a Medicaid provider. And the form is kind of like strict on how you fill it out, but our managed care organizations, Medicaid in each county has their own system in place, and they have websites where you can find the forms and also how to fill it out.
And there are some other abbreviations that are there within the IBHS, like the people who are providing those services. So what are those? What are their titles, and what do people typically call them, and things like that?
Yeah, so all those titles and acronyms changed recently too, just to confuse everybody. So there's a behavioral consultant, or a BC, and that is, I think of them as the lead clinician. So their role is to create treatment plan interventions, consult with the adults like parents and teachers and other caregivers, and they also kind of supervise some of the roles underneath. So there is what used to be called a TSS is now called a behavioral health technician, or BHT. And that is somebody who does more of the direct care or therapy with the individual who the service is prescribed for. The other role is an MT, or a mobile therapist. And I think of an MT as kind of like an outpatient therapist that comes to the child. So they're doing more of like the social emotional learning. And then a couple other roles. There's a BCBA, which is oh gosh, this is all these acronyms. When
Behavioral
they're
analysis or something?
yes.
Okay.
So there's kind of like two tracks, which I also didn't mention at the beginning. So IBHS now, there's kind of these like two directions you can go. You can get IBHS ABA and IBHS individual services. And so the roles are like slightly different within both of those tracks. IBHS ABA tends to be a little bit more intensive of a service, and for our kiddos who really need more like more supports needs, I guess is how I would qualify that. So a lot of really heavy like skill acquisition. So our kiddos who might be like non-speaking and need a lot of interventions surrounding communication skills, that would probably be a better option.
So that ABA, is that standing for Applied Behavioral Analysis?
Oh,
That
yes.
same
Yes. I'm
thing?
sorry.
Okay.
Yeah.
Yeah, no, that's okay. I was just trying to make sure it's all. So IBHS, ABA is one option, and then the other is individualized, which is
Mhm.
that where the Is that what you were describing earlier with the?
Yeah, and
Okay.
sometimes our individuals can kind of do either. That's the two tracks was something that was just started more recently, and there was a change in terms of like the therapists credentialing and education had to be slightly different depending on which populations that they worked with. But there's a lot of similarities between the interventions and strategies that therapists use. So it really depends on the kiddo, which one I may recommend. And sometimes kiddos may start off getting IBHS, ABA, but then their provider might suggest a change to the individual side, and that's okay too.
Okay, great. And then, so that's one level of service.
Mhm.
What other levels exist? Let's say if a child has different needs than what we've described.
Sure. Some other things that I also forgot to mention when I was talking about outpatient therapy is that there is also school-based therapy. And school-based therapy is essentially like outpatient therapy, but it's happening during the school day within the school building. And so our school districts are contracting with outside agencies, and then they're providing a therapist to go into the school buildings, and they kind of give them an office and say, okay, you can take a caseload of our kiddos and see them during the school day. And so they're billing insurance within the school building just like they would in an office, and they're providing therapy through the day. So that's one of the less intensive before the IBHS option that I forgot to mention.
Okay.
So then thinking about, so we have school-based and outpatient therapy is kind of like the bottom, less intensive. And then IBHS, kind of similarly, there's ABA services that are center-based, which means that they are an intensive service, but instead of coming to the home, you're bringing your kiddo to that center. And oftentimes it's several hours a day and several days a week. So it's kind of equally as intensive as IBHS services, but it's happening in a center instead.
Okay.
And during that piece, like sometimes even if it's like primarily in the center, then it also there might be like a small percentage of time that's happening in the home as well, just for that, like we call it continuity of care. So that way, we're also consulting with parents, making sure that they're doing the interventions that are being done at the centers as well. And then above wraparound or the IBHS services, there are a few other things. So there's family-based mental health services. We call it FBMH. That service is in the home, a team of two therapists, and there's oftentimes more significant needs with not just the individual, but sometimes within the family system. So there might be more than one individual within the family that has mental health needs or behavioral health needs. And this team can go in and kind of help everybody. So the kiddo can be the identified client, but they can help the whole family. This option is really good, for families where we need to work on like foundational skills, like let's implement some really good boundaries and limits and home rules. Or sometimes if there's a lot of differences between parenting styles or caregivers or families that have two homes, I think that is also an option. And that also requires like a script per se. So coming to see me for a psychological evaluation, and I could recommend that service as part of the evaluation. There is also a form called the family-based prescription letter that a pediatrician can fill out, or a licensed therapist, I believe, can also fill it out.
Would that require that they've tried and failed prior techniques, or can you go right to that family based if a family needs it?
I think ideally they would have tried other less intensive options first, but sometimes we don't capture people until the level of need is that significant that they need family-based services.
Great. Okay, wonderful. And then anything beyond that, or is that then we're getting into
Sure.
inpatient care?
Yeah, there's like partial
Uh-huh.
hospitalization and hospitalization
Okay.
services. The one option too that we didn't discuss is psychiatry services, which kind of like they're part of mental health services, but a little bit off to the side sometimes. So families can seek psychiatry services if there are concerns that medication may be able to address. But one thing that I always tell families and colleagues is that medication is never a recommendation of mine alone. It can be used really effectively in conjunction with behavioral health services, but a lot of times the therapy is the great place to start, because or in collaboration with psychiatry services, because there's a lot of behavioral interventions, coaching, parent coaching, skill acquisition that needs to be done that medication can't do.
Okay. Wow, this has been super helpful. Are there other areas or anything else that you wanted to touch on that we didn't touch on yet during this podcast, or any final thoughts, summaries that you would want to give to a family?
Yeah, I think one thing that we do really well in our center is we make sure that all of our individuals are up to date with their annual medical appointments. And this is so important for our population because our individuals are at risk for certain medical needs. And sometimes when there is a behavioral presentation that's new or different, and we want to make sure and rule out medical first. So an example is a lot of our individuals that get constipated become irritable, and then we might notice more tantrums or aggression or something. So if we didn't consider the potential for a medical etiology or reason, then I think that we're missing the mark sometimes. And another, really good example is sleep apnea. So, untreated or maybe unidentified sleep apnea can look very behavioral or behavioral health land issue, but if we are not addressing it medically, then that's a really big problem. So, making sure that our families are getting, their regular, consistent medical appointments, and also, checking that out. If there's a sudden change in your individual's presentation or a really big increase or something out of the blue, maybe consulting with your medical team is a very good first place to start.
That's great. Yeah, thank you for that reminder. Wow, we are just, like I said, over and over and over again during this podcast, we are just so blessed to have you on the team and to be
Thank
able
you.
to have this way of referring our patients to you to get the expert advice and evaluations that you're able to provide. So thank you for joining us on the podcast and for
Thank
being a
you.
part of our team.
Thank you for having me.
Yeah, and to our listeners, if you have any other questions that you would like us to address, please do reach out to Down Syndrome Center at chp.edu. As you can imagine, we've been doing this podcast for many years, and so we've covered a lot of topics. But if there are topics that we have not covered or you'd like us to cover again, please do let us know. And as always, everything that we do at our Down Syndrome Center is covered through philanthropy. And so if you are able and willing to be a part of our team and support the work that we do, including this podcast, please go to givetochildrens.org/Down Syndrome Center. But until next time, bye bye.